Dr. Praneeth?
Good evening, sir.
Good evening,
I'm just
Praneeth.
trying to share it, sir.
Yes, please. Switch on
Good
your
evening,
video,
sir.
ma. Dr. Praneeth?
Sir, am I visible, sir?
Yes, good. I think there is a light behind you. Can you switch off or face the light? That should be better.
So is this better, sir? I mean, that's
Don't worry, just forget it. If, maybe we are already close to 8 and I don't want any stress on this.
Sir, good evening, sir.
Good
Vidisha
evening,
has joined, sir. Yeah.
All right, all
Good
right.
evening, sir.
Vidisha, again, can you face the light, ma? You have a light behind you. Can you reseat
Sorry, sir.
yourself?
Sorry, sir, I can't hear you.
No. There is a bright light behind you. If you can reorient yourself, it makes things much easier. Vidisha, is your network all right? Vidisha? Praneeth?
yes, sir.
Praneeth, if, maybe you can go as the first candidate because if Vidisha is having challenges in setting things right, she can
Good
present
evening,
as the
sir.
second
Sir,
candidate.
can you hear me?
Vidisha, you go second. I've just asked Dr. Praneeth to come in. Don't worry, you'll have your turn.
Okay, sir. Okay.
Friend, good evening, everyone. Warm welcome to all of you. And we'll be glad to have a lot of faculty today to discuss. We have Professor Ishwar sir to join shortly. Professor Nilutpal Bhattacharya from Assam Medical College, Jorat. Professor Rachna Gupta, Shyam Medical College, Reva. Professor Ganesh Kumar from Government Medical College, Viluppuram. And Professor Prakash K. Sasmal.
Good evening, all.
And Robinson is expected shortly. Good evening, sir. And we have our own course faculty from PG Clinics. We have Dr. Khanna sir, A.K. Khanna sir joining. We have Dr. Nandan Sahai sir, Ajay Nandan Sahai sir, and Krit joining us. Warm welcome to all of you. Without much ado, I think we have already last couple of minutes. We have two important presentations. One kindly contributed by Dr. Professor Shyamkumar Gupta, head of the department at GMC Jammu. Dr. Vidisha, she'll be presenting on soft tissue tumor. And Dr. Praneeth V. Taneti from Sri Ramchandra Institute of Higher Education and Research, kindly contributed by Professor Sidian sir. Praneeth, please introduce yourself and start your presentation. Faculty, kindly take over. Good luck to you, Dr. Praneeth.
Thank you, sir. Sir, is my screen visible, sir?
You are good to go.
Yes. Yes, Praneeth.
Good evening, sirs. I'm Dr. Praneeth. I'm a third-year postgraduate resident from Ramchandra Medical Center, Chennai. I'm presenting a case on thyroid swelling under the guidance of Professor C.D. Narayanan, sir. Sir, can I start my presentation, sir?
Yes, please.
So, I'm presenting a case of a 63-year-old female who's a resident of Chennai, homemaker who presented to a general surgery clinic with chief complaints of swelling in the front of the neck for the past 6 years, complaints of insomnia for 2 months, and complaints of palpitations for 2 months. Going to the history of present illness, the patient was apparently asymptomatic 6 years ago when she noticed a swelling in the front of her neck, which was insidious in onset, initially which was small in size, gradually progressed in size to attain the current size. She also has complaints of insomnia for the past 2 months and complaints of palpitations for the past 2 months. No complaints of pain associated with the swelling, no complaints of sudden or rapid increase in size of the swelling, no complaints of dysphagia, no history of difficulty in breathing, no history of syncope, no history of hoarseness or recent change in voice, no history of other swellings in the neck, no history of bony swelling, no history of loss of weight or gain of weight, no history of loss of appetite, no history of heat or cold intolerance, and no history suggestive of distant metastasis. Going to my past history, the patient is in case of systemic hypertension for the past 25 years and is on regular medication. History of sterilization was done 38 years ago, and history of hysterectomy with bilateral salpingo-oophorectomy done 25 years ago. Patient gives no history of radiation exposure in the past. Menstrual history, patient attained menarche at the age of 13 years and hysterectomy was done 25 years ago. The cause, according to the patient, being a fibroid, but records of which were unavailable. Obstetric history, the patient has an obstetric formula of P3L3 with 3 normal vaginal deliveries. Personal history, patient consumes a mixed diet, consumes iodized salt, normal appetite, and normal bowel and bladder habits. Drug history, the patient does not give any history of intake of goitrogenic medication. Family history, no history of thyroid disease in the family and no history of any malignancies in the family. Coming to the summary of my history, patient is a 63-year-old female who's a known case of systemic hypertension, presented with the swelling in the front of her neck for 6 years, along with complaints of insomnia and palpitation for the past 2 months. No history of any pressure symptoms or no history suggestive of malignancy.
Sorry. Dr. Pradeep, you can tell us the size on history also. Just go to your first slide.
Sir?
Could you go to your first slide? Can you hear me?
Yes, sir.
Yeah. Could you go to your first slide? Yeah. Small size, current size. You can tell us approximately.
Yes, sir.
Can't you? So what was the size?
Initially, when she, yes, sir. When she observed, she said it was the size of it was around 2 into 2 centimeters. It's very small size. She's shown it was around the size of a lemon. She's told, sir. Now it's progressed to the size almost occupying entire aspect of her neck, sir. Anterior aspect. It's almost 10 into 8 into 9 centimeters in size, sir.
Very rapid increase in 2 months, isn't it?
No, sir. 6 years history of swelling, sir. There's no recent increase in size.
Now, insomnia and palpitation. Have they anything got to do with a thyroid swelling?
Sir, there could be a it could be a multinodular goitre, sir, where secondary thyrotoxicosis.
No, thyrotoxicosis. Does the patient have insomnia?
Sleep disturbances they can have. So difficulty in sleeping, sir.
Difficulty in sleeping. I mean, I've not come across insomnia in any case of hyperthyroidism. This word insomnia doesn't come. There can be a sense of doom or can be insomnia or not. Okay, what about palpitation? What do you mean by palpitation? Does the heart race? Or does she have the sensation of the heart beating?
Yes, sir. She feels. Yes, sir. She has the sensation of heart beating intermittently for the past 2 months.
It's all the time, or does it increase or decrease?
Intermittent, sir. She has a few episodes. She had a few episodes in the past 2 months. It was intermittent, sir. In the past couple of weeks, she didn't have any, sir.
Okay. So you think this is also related to a thyroid?
So since it was a long-standing swelling, which was gradually increasing in size, could be a secondary thyrotoxicosis with both these additional.
Is palpitation related to any thyroid condition?
Graves
yes,
disease.
it is. Right? If you know the Vane's criteria, do you know what is Vane's criteria?
Yes, sir. Criteria for thyrotoxicosis. A score of more than 19 indicates thyrotoxicosis. 11 to 19 is equivocal. Less than 11 is unlikely of
The palpitation
thyrotoxicosis.
is given 2+ in that, isn't
Yes, sir.
it? But there's no mention of
Yes, sir.
insomnia anywhere. Okay. Dysphagia. Difficulty in breathing. Why do you think ask this question for dysphagia?
So, increase in size causing pressure symptoms over the esophagus, sir.
You think this is a benign condition or a malignant one?
So, based on the history, there are no symptoms suggestive of malignancy, sir. For example, voice change, dyspnea, or even difficulty in swallowing, swelling elsewhere.
Right. Dysphagia is very rare. It has to go behind the trachea and involve the esophagus. Right?
Yes,
So
sir.
dysphagia, okay, if the patient complains of it, fine. Don't mention it that there's no complaint of dysphagia.
Okay, sir.
The positive has to be made. A negative has got no value.
Okay, sir.
Right. Next slide, please. Okay, now you look in your history, you got to find out whether it's a solitary lump or a multiple lump. Is it functional? And it is benign or malignant. These three things in a thyroid case, biohistory you have to prove.
Yes, sir.
An examination. So is it solitary? We don't know. She just says that there's one swelling. It could be multiple, we don't know. Is it functional?
Sir, insomnia and palpitation. I mean, sleep disturbance and palpitations were the only positive symptoms, sir. No other positive history was there.
So you just write no symptoms suggestive of hyper or hypothyroidism. I mean, history of loss of weight. Loss of appetite can be because of anything. What is important here is that loss of appetite or increased normal appetite is weight loss despite normal appetite, isn't it? That is more important than
Yes,
the
sir.
patient is having weight loss in spite of normal appetite. Just
Yes, sir.
history of loss of appetite and loss of gain of weight is not important here. It has to be associated with weight, has to be associated with appetite.
Yes, sir.
You get me? You can't disconnect these two findings. Okay, next slide, please. Hypertension, okay. Sterilization, what has this got to do with your case? History of sterilization 38 years ago.
Sir,
Just
it
for
was just yes, sir. Just the past surgical. Yes, sir.
She's undergone hysterectomy, which is what I'm trying to say that an MBBS in an MBBS exam, all this kind of thing matters. Here, in an MS exam, these kind of things which don't affect your case is better avoided. Some people say you should take it. I personally think it should be avoided unless it affects your history of hysterectomy is important because it tells you that if the patient, why did she undergo hysterectomy 25 years ago? What was the reason for it?
It was. She said it was a large fibroid for which they operated, sir. The records we didn't have, sir. Okay. It was just a large fibroid in the uterus, which was causing menorrhagia.
Associated with thyrotoxic associated or hypothyroidism is associated with menstrual disorders, and sometimes they undergo hysterectomy. Radiation exposure. Okay, next slide. Is she on any drugs just now?
No, sir. No, she's only for systemic hypertension. She's on medication, so she's not on any other. She is on amlodipine, sir.
You have to mention that, no? History of you just said history of hypertension, but you've not taken in drug history. Is she taking any medications? Was she seen with such a large 10 centimeters? She must have seen some doctor before this. She couldn't be walking to your hospital.
Actually, she had the swelling for 6 years, sir, for which she didn't consult anyone. Only with the recent onset of palpitations, she approached us, sir. She did not go anywhere else for the swellings.
Okay, next slide, please. Next slide. how it is solved. Okay, you've taken drug history. So drug history, no history of any goitrogenic medicine. What goitrogenic medicine are you talking about?
Sir, amiodarone, lithium.
Any more common drug? Used to be used in tuberculosis, sometimes still used.
Not sure, sir.
PAS. PAS. Okay. Okay. Next, just go to the no history. Okay. So what do you think you're dealing with now? She's got insomnia. At 63, most people get insomnia. That's not much of an issue. Palpitation for 2 months. So what do you think this is?
Sir, it's thyroid swelling, a goiter with potentially secondary thyrotoxicosis, sir, based on palpitations alone.
Okay. Anyone else, sir? Hello.
Dr. Sasmal, Dr. Nilotpal are thus.
Can I come in?
Please, sir, please.
Yeah, sir. So, as actually Rajesh sir suggested, it's a good thing point. You should be noting that, students. One thing is that in your summary, you have mentioned that 63 years old with swelling in front of the neck for 6 years and complaints of insomnia palpitations. You have just put it. So, why are you thinking in your clinical history based on this? So, what is your diagnosis you are expecting? What type of swelling?
Sir, a benign swelling, sir.
No, benign swelling of which organ?
Thyroid, sir.
Thyroid. Why are you thinking so it is a thyroid?
So, first is based on the location with the gradual increase in size, sir, in the front of the neck with a gradual increase over 6 years. Could be some form of goiter, sir. And other than the last 2 months of symptoms, she didn't have any other symptoms, sir.
Good. So one should be answering as you answered actually, as it is based on the anatomical location. So that is why common one. Differentials will be coming, of course, after the clinical examination. Okay, you took a radiation history. Can you just mention
Yes,
what
sir.
are the conditions where radiation is given usually in the childhood days?
Hodgkin's lymphoma, sir.
Anything else? Large any adenoids, thymus, tonsillitis in the past used to be given. So lymphoma is one of the condition also. One should be knowing because this is the next question which the examiner will be asking you because radiation in the childhood you should be knowing few conditions. Okay. So you took the family history also?
Yes, sir. Family history, there was no thyroid disease in the family and also no history of any malignancies in her immediate family, sir.
Okay,
First
good.
and second degree relatives.
What malignancy particularly you have taken the history? Which all runs
Sir,
in family?
I asked for thyroid and parathyroid, sir. It could be medullary thyroid malignancy associated with Men's syndrome, any pancreatic malignancy, and also any pheochromocytoma, any adrenal malignancies, sir.
Okay, good. So you wanted to rule out some Mann syndrome, or you wanted also, shouldn't you also rule out some benign conditions of the thyroid gland which can run in the families?
Yes, sir. It could be dysharmonic goiter. It could be.
Very good. Yes.
I've
These are good.
asked.
Yes, runs in families, and of course, geographical, if particularly in some of the hilly areas, if they're coming there, then also it can be in the families, it will be present in multiple members. Did you ask anything about the treatment history?
She didn't receive any treatment for this swelling, sir. This is the first time she's consulting a doctor for this treatment.
Okay, so you meant to say, has it got any relationship with your diagnosis after the examination? Can you make any diagnosis out of this? Because no treatments he has received in the last 6 years.
Yes, sir.
So can you make anything from the history itself?
It could be a
please.
Long-standing goiter, sir, which would have developed toxic symptoms recently, sir.
Got it. So probably you'll be answering this question in the future, in the subsequent after the examination, because this makes what do you mean by no? We should be asking that later on. Okay, this till the examination, till the history part, I am done. Any other examiner?
Other faculty, Nellutpal sir, Kanna sir.
Did you ask only about the family members' history, or did you ask about the society history also?
Sir, I primarily asked about the family members, sir. And she's hailing from Chennai, sir, not in a goitrogenic belt, sir. She's.
You must also ask about the surrounding people who are the persons living around that, whether anyone had the thyroid problem. What are the bowel of your patient?
Sorry, sir.
What is the bowel habit of your patient?
Sir, regular bowel habits, sir. She has no disturbances in bowel or bladder habits.
Patient with a thyroid problem, can they have any abnormality?
Bowel and bladder abnormalities in hyper or hypothyroidism we might encounter, sir.
If somebody is having a lot of diarrhea is there,
yes, sir.
What you will
hyperthyroidism, we might encounter patients with diarrhea, sir.
Anything else? If there is a diarrhea is there associated with thyroid swelling, apart from the hyperthyroidism, will you think of anything else? Medullary carcinoma. So the main presentation of the medullary carcinoma is the diarrhea.
Yes, sir.
The chance of having a secondary thyrotoxicosis from a multinodular goiter.
Sir?
What is the chance of multinodular goiter converting into thyrotoxicosis?
Around 20%, sir.
5 to 10%. What are the other complications which can occur?
So conversion to long-standing goiter can, the possibility of conversion to a follicular neoplasm can be there, sir. Hemorrhage into the cyst can be a complication, sir.
Examination.
Dr. Praneeth?
Yes, sir.
What made you think that this swelling is the symptoms are related to thyrotoxicosis, this symptom of insomnia and what you said, palpitation?
Palpitations.
Is it,
Sir,
what made you thought that this is due to thyrotoxicosis?
Sir,
Have you
she
from
has.
history, have you ruled out any other condition? Can it be possible that a 63-year-old can develop palpitation and insomnia from other causes also?
Yes, sir. But in our case, she didn't have any known comorbidities, sir. But she could have developed the cardiac issues simultaneously as well, sir. I potentially thought because it's a thyroid swelling, there could be a possibility of a secondary thyrotoxicosis, sir.
Were there any primary symptoms of thyrotoxicosis?
No, sir. Initially, when the swelling started, she had no symptoms, sir. She noticed it about 6 years ago, and at that time, she didn't have any symptoms, sir. It was only a swelling. So because she was asymptomatic, she did not consult any healthcare professional.
Okay. As such, there were no symptoms of any weight loss, means
No, sir.
unintentional weight loss, nothing as such.
No, sir.
Okay. Fine, you have done well with the history part. I think we can proceed to the clinical examination, if other examiners allow.
Yeah, okay. Clinical examination.
general examination. So the patient was examined after obtaining informed consent very room with adequate exposure and privacy in a sitting position. The patient was moderately built and nourished with a BMI of 23.6 kg per meter square. She's conscious, oriented to time, place, and person. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. No eye signs were noted, and fine tremors were noted in the hands. Vitals, blood pressure was 120 per 80 millimeters of mercury in the left arm in sitting position. Pulse rate was 74 beats per minute in the left radial artery. Regular in rhythm, good volume and normal character. Room air saturation was 99% and respiratory rate was 16 cycles per minute. Temperature was 98 degrees Fahrenheit. In examination of the neck, a single swelling of about 80 to 9 centimeters was noted in the anterior aspect of the neck in the thyroid region. Surface appeared smooth on inspection. The superior extent was about 8 centimeters above the sternal notch. Inferiorly, the lower border could not be made out. Lateral extent on the left side was up to the anterior border sternocleidomastoid, and right lateral extent was noted. The swelling was noted extending beyond the anterior border sternocleidomastoid. Continuing inspection, swelling moves with deglutition, does not move with protrusion of tongue. No scars, sinuses, or dilated veins were noted over the swelling. Thyroid prominence could not be made out, and no other swellings were noted in the neck, and Pemberton sign was negative. Palpation, inspected findings were confirmed on palpation, and there was no local rise of temperature or no tenderness. Diffuse enlargement of thyroid gland was noted involving both lobes and isthmus, which had a vertical extent of about 8 centimeters and a horizontal extent of 9 centimeters. Surface on palpation was nodular. The swelling was firm in consistency. Extent was similarly confirmed. Inspected findings of the extent were confirmed on palpation. With the lower border not being able to palpate even on palpation. In Caucus test, there was no stridor. Tracheal position could not be assessed as the thyroid prominence could not be palpated. Carotid pulsations, right side carotid pulsations are noted to be displaced laterally, and there was no thrill palpable. Left carotid pulsations were in the normal limit, in a normal position, and no palpable cervical lymph nodes were noted. Percussion over the sternum showed a dull note, and on auscultation, there's no bruit heard. Systemic examination was within normal limits. Cardiovascular system, respiratory system, and central nervous system were normal, except for the fine tremors which are noted, with no focal neurological deficits, and abdomen was soft and non-tender, no palpable organomegaly or bowel sounds were normal. Musculoskeletal system, there was no spine or bony tenderness, and no palpable swellings over the skull. Coming to the summary of my case, a 63-year-old female who's a known hypertensive presented with complaints of swelling over the anterior aspect of the neck for the past 6 years, with complaints of insomnia and palpitations for the past 2 months. Fine tremors were noted with a single swelling occupying both the lobes of thyroid along with the isthmus, which is moving on deglutition. Lower border was not palpable. No features of compression or cervical lymphadenopathy were elicited on examinations.
Okay. So what's the
provisional? So I would like to give a provisional diagnosis of a multinodular goiter with retrosternal extension with features suggestive of secondary thyrotoxicosis.
Okay, let's go to your general examination then. Let's see whether you prove this in your examinations. Okay, nothing here. Tremors noted in the hands. How do you note for tremors in the hands?
Sir, extended the hands parallel to each other, straight, sir. We placed the paper on top and we could feel the movement of the paper, sir. Fine tremors, sir.
So at age of 63, fine tremors would be normal or would be thyroid induced?
Sir, it could be physiological at 63
because you're not
years of age.
finding any, look, the patient doesn't have any other feature of thyrotoxicosis.
Yes, sir.
So if you put this, if you put tremors, you have to explain whether it's due to thyrotoxicosis or is it age related.
You have tested only the hand tremor, Praneet? Only the hand tremor?
Yes,
have you
sir.
tested the tongue?
Yes, sir.
No.
Tongue, there were no fasciculations noted, sir.
No, what is? So, what do you come to? What is the conclusion then? Tongue is normal, no tremors there, only in the hand.
And that also in a 60 plus aged person, I think.
Right? So
It could
this
be physiological, sir, but
It
yes,
can
sir.
be physiological. Yes, yes.
no, Dr. Praneeth, this is what I'm trying to say.
Yes, sir.
Don't put in things just for completion's sake. Because I've noted
Yes,
it,
sir.
I'm going to do it for it. If you put it, then you got to explain why. Okay, next
Yes,
slide,
sir.
please.
Where is the pulse slide? Oh, yeah.
Yeah.
That also very regular.
Yes, sir. Regular, sir.
That is the thing I asked you. That's why in the history, that is it related to thyroid gland or it is just a physiological change that you are noticing in the patient?
Could be
So
physiological
what is
change,
there
sir.
to prove from history and clinical examination that this tremor and insomnia is related to thyroid gland? That is what I want to know. Is this the only thing you have?
Yes, sir.
So Praneeth, what I'm trying to say that you're on a thin ice. You're skating on thin ice by propping up your diagnosis on just two factors, which are insignificant, which can be age related, isn't it?
Yes, sir.
Right. Okay, next slide, please. Next slide. Okay, next slide. Is the lower margin visible on deglutition?
No, sir. No, sir.
Next slide, please. Because so there is a single swelling, 8 into 8. Right.
Yes, sir. 8, 9 centimeters swelling, sir.
Okay, next slide, please. Palpation.
Vertical diameter is only the palpatory part you are mentioning, isn't it? I think
Yes,
the
sir.
lower border is not palpable, no?
Yes, sir. 8 centimeters above the sternal knot, sir.
Above the sternum.
The surface is nodular or is it bossylated? Nodular means what? The
Bossylated,
small
sir.
nodules which can feel.
Nodules are there, sir. It was bossylated, sir.
Right. Okay, extent is fine. Next slide, please. Next slide.
And is it of the same consistency all over the swelling or variegated?
Yes,
So
sir.
again,
It was firm and consistency throughout, sir.
Okay, what
just
is
like
thyroid
the
paradox? What do you mean by thyroid paradox?
Sir?
You said firm in consistency. What is
Yes,
thyroid
sir.
paradox?
regarding
term called-
consistency, what is the paradox in case of thyroid swelling examination regarding consistency?
Okay.
It's actually something feels like something. I'm just giving you the hint.
Okay, cystic swellings feel firm and solid swellings feel soft. That's the paradox. Okay, that's because of the
High cellular.
Deep cervical.
Right.
No. It's because of the high cellularity.
Yeah. There's increased aspect. Next slide, please. Dull knot over sternum.
Have you
Okay.
tested for the Pemberton sign?
Yes, sir. I mentioned it, sir. In,
Yeah, yes. Why did you test for Pemberton's?
Sir, because lower border was visible, sir.
So what does that tell you?
retrosternal extension causing compression over. If there's any compression on the superior vena cava by a retrosternally extended goiter, so there's compression in the thoracic outlets.
Okay. So how does Pemberton sign elicit this? Brings out this the sign. What is the basis behind Pemberton sign?
So
do you do it?
elevation of both the hands above the head. Sir, we ask the patient to elevate both the hands above the head with arms close to the ear, sir.
And then
Touching the ears.
Basically, arms touching the ears, sir. It reduces the thoracic outlet space, sir, by the overhead abduction of the scapula, reduction of the thoracic outlet
that's fine.
space.
That's fine. That's fine. Right. Next slide, please. Okay. Okay, that's fine. So heart, there's nothing, right?
No, sir. No, sir.
Yeah. Next slide. So what's your now? Let's come to your diagnosis. Let's come to your diagnosis. So multinodular. Why did you say multinodular? Do you feel different nodules?
Sir, it was more of a bosselated
Diffuse.
surface on a diffusely enlarged gland, sir.
It's a diffuse swelling with a smooth surface, I think you mentioned.
So smooth was on inspection, sir. On palpation, the surface was bosselated, sir.
What is the difference between nodularity and bossellation?
So this, we will be able to palpate discrete nodules separately on if it's nodular, sir. If there's a diffuse enlargement with minor surface elevations, we will call it bosselated, sir.
So it's a uniform elevation, not a irregular elevation, no?
Yes, sir.
It's a smooth elevation that you call it bosselated.
Yes,
Does
sir.
it make it fit to the criteria of multinodular goiter? Is there any other method of checking whether there are any nodules or not?
So Kyle's method, sir. When
Yeah, Kyle's method. Have you checked for that? Have you checked the posterior surface of the thyroid gland?
Sir, Kyle's method, I couldn't feel any other nodules, sir. It was just the surface bossellation.
So it's a
by
uniform swelling.
Yes, sir.
Uniformly enlarged thyroid gland, just like how you feel
Yes,
in
sir.
a this one primary goiter. Right,
So
in a
Praneet,
Graves' disease.
would you like to change your professional diagnosis?
Sir, I would want to change it to multinodular goiter with retrosternal extension. I wouldn't like to mention the secondary thyrotoxicosis features, sir.
No, I would like to change it to just colloid goiter. Colloid goiter.
Yes, colloid goiter, right.
Why multinodular? Just say colloid goiter. If you get an ultrasound and then it comes, you can change it. Okay, what's the differential now? One is this colloid goiter. What's the differential?
Just few clinical questions, Dr. Rajiv. Just few clinical questions to add to your questions. Then we can proceed to the differential diagnosis.
Sure, sir, please.
Yeah, Dr. Praneeth. So, what was the shape of the swelling?
Yes, sir. It was swelling extending from right sternocleidomastoid to the left, sir, and vertically lower border could not be assessed, sir. So the
So
shape.
you would say it was just an oblong swelling or an oval swelling, solitary one?
Yes, sir.
So it was not taking the shape of the typical thyroid, that is a butterfly shape, two lobes?
No, sir. It was a diffuse enlargement, sir.
So diffuse enlargement of the thyroid gland, still will it take the shape of the thyroid gland or it will be losing it?
It should be taking the shape, sir, but this was a long-standing swelling, so. But on palpation, we could not palpate the lower border, and the upper border also was almost 8 centimeters. It was uniform. It was in the shape of the classical thyroid gland.
Classical. Okay. So definitely the thyroid, even if it is diffusely enlarged, it will be roughly taking the shape of the thyroid gland, that is two wings of the butterfly. So in case of a thyroid swelling, usually, as you have mentioned, the vertical size dimension, the dimension should be taken of individual lobe with the isthmus also separately, not as a single solitary swelling. Got my point? Because if you mention it solitary one, that means your diagnosis will be not a goiter at all. It will be a solitary thyroid nodule involving one particular lobe.
Yes, sir.
Okay. So question related to the tremor. So your tremor, you told, how many types of tremor do you know from your just recall memory in the medicine? How many types of tremors are there?
Fine and coarse tremors.
Fine and coarse. What do you mean by resting tremor? What do you mean by intense and tremor? And what do you mean by
Resting tremor? Resting tremor occurs in
Very good.
Parkinson's, sir. Intentional tremor in cerebellar pathologies, sir.
Yes, good. So in case of thyroid, what happens?
It should be
Postural.
intentional tremor.
Postural. You ask the patient to raise extend the fingers and the hand before you and slightly fanning. Then you will be marking some amount of tremor. It is not present in the resting phase. Or when you ask the patient to do something, if there is a tremor, then it is not a postural tremor. Got my point? So these
Yes,
all
sir.
small things will be making a difference. Now I'll be asking you about the coccus test. Did you do that?
Sir, we just applied gentle pressure, sir, and there was no stridor.
What was your position?
Sir, I was standing in front of the patient, sir.
Ideally, the coccus test
With
should be done standing behind, gentle pressure applied. So, what will be the change? What do you have the inference of this coccus test?
is any on pressure, there'll be stridor on applying pressure, sir. So it is it's close to the trachea, sir, basically causing obstructive symptoms.
Obstructive symptoms, or there may be presence of sometimes tracheomalacia,
Infiltrate.
compression.
Yes.
No. You told something infiltration. Infiltration, does it occur? Infiltration, what will be the difference if there is tracheal infiltration because of malignancy? Is there any difference?
Hemoptysis.
No, stridor, any difference in the stridor in both? One is a coccus because
No,
of
sir.
compression. One is a the stridor because of infiltration at rest.
Infiltration stridor should be present at all times, sir. And
At all times.
compression, when we apply pressure, compression should be present, sir.
Very good. Now coming to something about the thrill you mentioned. Thrill.
Yes, sir. There was no thrill, sir.
Okay. Where did you examine?
Sir, at the upper pole, sir.
Upper
pole of
why
both.
is it?
Sir, because the superior thyroid artery is a direct branch of the external carotid, sir, and it's the superficial most arterial supply to the thyroid gland, sir.
It comes from the superior aspect, so you can easily, whereas the inferior thyroid artery comes from behind. Okay. So the last question from my side will be carotid pulse. Did you palpate?
Yes, sir.
Okay. Where did you palpate it?
Sir, in the left side, it was against the chestnut tubercle, sir. At the level of C6, it was a normal position, sir, in the carotid triangle. In the right side, it was slightly displaced posteriorly, sir.
Displaced. So if it is absent, what is that called as?
Very sense.
Very good. Over to other evaluators. Thank you.
You were repeatedly telling us that the patient has got a secondary thyrotoxicosis. So what are the tests you have done to see the patient has a thyrotoxicosis or not, apart from the history on the examination?
Sir, on examination, except for the fine tremors, there were no other findings suggestive of any thyrotoxicosis, sir. There were no eye signs. There was no abnormality in the systemic examination of other systems as well. So it was only the fine tremors which was towards thyrotoxicosis.
Asking you, what are the things you really look for that? One, you said it's the tremors. Second, you said the eye signs. What are the other things? Did you examine the CNS of this patient?
Yes, sir.
In the CNS examination, what are the things you see in a patient with thyroid swelling? Where you are suspecting the patient is having thyrotoxicosis.
The patients will generally be more irritable, sir.
An examination. Did you check for the reflexes here?
Sir?
Check for the reflexes. Have you
No,
checked
sir.
for the muscle tone? What is the muscle tone in case of thyrotoxicosis?
Rigid.
What is proximal myopathy?
Involving the proximal muscles of the limbs, the thigh and the arms.
How do you test for the proximal myopathy? You ask the patient to stand up from a squatting position, and the patient will not be able to stand. Okay. You have to check for all the tendon reflexes. If there is hyperreflexia is there is more chance of thyrotoxicosis. If the diminished reflexes are there, more chance of having the
Sorry, sir, your voice is breaking, sir.
voice is not coming.
Hello, sir.
What will happen to the
Hello.
reflex thyroid swelling? Tendon reflexes, you will check for the tendon reflexes. What will happen?
Hello, sir.
You're not getting my voice?
Yes, sir.
Sorry, then.
Praneeth, sir is asking, what do you expect in tendon reflex in a case of thyrotoxicosis? Can you hear us? Hello? I think we've lost him. Praneeth, are you there?
Praneeth? I think.
We lost him.
Praneeth, are you with us? Dr. Praneeth?
Hello.
Can you hear us?
Sir, sorry, sir. There was some. Yes, sir. Yes, sir.
You are back now. Good luck, ma.
Yes, sir.
Praneeth, are you able to hear me?
Yes, sir.
Okay. I was asking that what happens to the tendon reflexes in thyroid?
So they'll be exaggerated, sir, if there's CN manifestations.
To sustain your diagnosis of thyrotoxicosis, you have to carry out all these things. Apart from the tremors, the eye signs, reflexes, myopathy, then only probably you can say that probably the patient has got a thyrotoxicosis. What are the various types of retrosternal goiter?
So based on Rudolph's classification, it can be classified into three types, sir. It's basically type 1 is above the arch of aorta, type 2 is at the level of aorta, type 3 is going below the level of arch of aorta, sir. It could be primary or it could be an extension from the neck, sir. In primary type, it could be of mediastinal origin where mediastinal blood supply is there. If it's extending from the neck, it could be the arterial supplies through the inferior thyroid vessels, sir.
What is the plunging type of retrosternal goiter?
Sir, when patients extend the neck or when there's an increase in the interthoracic pressure, the lower border comes above the sternal angle, sir.
Okay.
Okay,
So how will
Praneeth.
Please.
Okay, how will you manage the case? Let's go to the management. We got about 10, 20 minutes. Hello.
Yes, sir.
Let's go to the management.
Yes, sir.
How do you manage
Initially, we want to get a thyroid function test done, sir, to look for any derangement in the thyroid function test. Along with that, I'd like to get an ultrasound of the neck done, sir, and basic blood investigations along with it, sir.
Okay. So what have you got?
So based
Any
on
cardiac examination would you like to do?
sir, for the palpitations, I'd like to get a basic electrocardiogram done, along with, if necessary, more than 50 years of age, a 2D echocardiogram as well, sir.
Hello. Sunny?
Yes, sir.
Yeah. So
Yes, sir.
tell us the results. So you've done the investigation. What was the first
Yes, sir.
investigation got done?
Thyroid function test, sir. Free
thyroid?
T3, free T4, and
Why
to look for,
was your first
sir,
test?
sir, to look for if any hyper or hypothyroidism is there on the blood investigation,
So
sir.
clinically, you have said that you think the patient is euthyroid, isn't it?
Yes, sir.
So what's the fun of getting just to confirm your diagnosis? What would you have done first? What is the first investigation to be done in this case now? It's not thyroid function test. It's an ultrasound.
Ultrasound of the neck, sir.
Right. So have you got an ultrasound done?
Yes, sir.
Yeah. What's the report?
This is the entire thyroid gland appears enlarged with multiple nodules, sir. There is in the left lobe of thyroid a 5.2 into 4.7 into 2.8 centimeter nodule, which was TIRADS 3. And in the right lobe, there's a 1.1 into 0.9 into 1 centimeter nodule, sir. And after the USG neck and the TFT was within normal limits, we got an FNAC done as well, sir.
Hang on. Let's discuss the ultrasound first. So
Yes, sir.
what do you think the ultrasound tells you now?
Basic multinodular goiter, sir. Picture of multinodular goiter. There were 2 nodules, and the larger one was 5 into 4 into 2.8.
So why couldn't you palpate it? The largest one is 2 centimeters, isn't it?
Yes, sir.
Yeah. So a 2 centimeter thyroid nodule should be palpable. Why is it that you couldn't palpate it?
So the entire gland was enlarged, sir. So because of the diffuse enlargement, we couldn't separately palpate the nodules.
Okay. Suppose you could palpate this nodule during examination. What would you call this nodule?
Dominant nodule of multinodular goiter, sir.
Okay. So what's the dominant nodule? And what's the solitary thyroid nodule?
The largest. So in solitary thyroid nodule, there's a single nodule in the thyroid gland, whereas in dominant and multinodular goiter, the largest nodule which we see is dominant nodule of the multinodular goiter.
So on palpation, how do you say that this is a solitary nodule and this is a dominant nodule in a multinodular goiter?
Sir, if it's a nodule with surrounding thyroid not palpable, then we can call it a solitary nodule.
Right.
If
so the rest of the thyroid is not palpable, just a nodule is palpable, it's a solitary thyroid nodule, right? But if the rest of the thyroid is palpable and you have a node which juts out or which is prominent, it's called a dominant
nodule of MMs.
Now, what else will you look for in your ultrasound? One, you said that it's okay. There's a dominant nodule. What else?
So for in the nodule, in thyroid gland, we look for the nodules and the characteristics of the nodules, sir. Apart from the thyroid gland, we look for the characteristics we look for according to the TIRADS staging include echogenicity, sir. Echogenic foci with any microcalcifications. Then we look for the shape of the nodule, that is taller than wider or wider than taller. So the margins of the nodule being well defined.
Okay, Praneeth. One, you said you look for calcification, microcalcification.
Yes.
So what does microcalcification tell you? If there is
Features
microcalcification
suggestive of
and macro
is more towards benign diagnosis. So
why? Why is that micro is malignant and macro is generally considered benign? Why? Because in malignancy there is cell death. Fast multiplying cells, the cells die, right? And they get calcified. So you have microcalcification, right? Now you said taller than wider.
Yes.
Why? What does taller than wider and wider than taller mean?
The nodule vertical size more than the horizontal is more in favor of malignant or neoplastic
Again, the question why?
Why it appears?
Why is taller than wider considered to be seen in malignant cases? Is there in breast? Is there in thyroid? Why? Because malignant tumors tend to grow outwards towards the skin. You get me?
Yes.
That's why they are taller than wider.
Yes, sir.
Right. Okay. What else will you look for in your ultrasound?
Praneeth, you made a diagnosis of secondary thyrotoxicosis. Would you like to have any other signs supportive of your thyrotoxicosis? What do you expect in ultrasound? You got my question?
So increased vascularity, sir.
Okay. How will it be differentiated in case of malignant nodule? Because there is a vascularity increase even in malignant diseases also. It is in thyrotoxicosis also. So how will you differentiate by ultrasonography wise?
Malignant nodules will be more hypoechoic, sir.
Okay.
With increased.
No. If you put a Doppler, if you put a Doppler to look for the vascularity, how will you differentiate?
Malignancy, there will be a central area of necrosis, sir, but in benign ones, there will be central angiogenesis.
Yes. In case of malignant nodule, there will be vascularity more towards the periphery, less towards the center, because of the necrosis happens at the center. Whereas in thyrotoxicosis, it is a diffuse increased vascularity, so entire gland shows the increased vascularity. So ultrasonography sometimes differentiates on the vascular pattern whether it is a malignant thyroid disease or a multinodular goitres. Okay, continue.
Okay. So what else will you look for in ultrasound?
So shape taller than wider, sir, and after that, sir,
other than thyroid,
ill-defined
what else do you look for?
margins.
Other than thyroid, what else do you look for?
Sir, any cervical nodes, lymph nodes,
So are there any cervical nodes here?
No, sir, there were no cervical lymph nodes, sir.
Okay. So then you did your thyroid function test, which is normal, and did your FNAC. Why did you do your thyroid function test before doing an FNAC?
Yes, sir.
No, why did you
So,
have to
so
do
that if the patient, so to rule out thyrotoxicosis, it can lead to, in thyrotoxicosis, the gland can be highly vascular. There could be bleeding. So prior to FC, we wanted to rule out if there's any deranged thyroid function test.
So if the patient was thyrotoxic, then what would you have done?
So first brought the patient to a euthyroid state with anti-thyroid medication and then plan for an FNAC, sir.
Anti-thyroid medication. And any other way of bringing it down much faster? Any other way?
We can, so beta blockers we can give, sir, if the patient is symptomatic and give anti-thyroid.
Beta blockers for symptomatic.
Yes.
All the tremors and all that kind of thing. What is the role of Lugol's iodine?
Low-dose iodine, we can give it prior to any procedure or surgery for
So what's the role?
10
What is the
days.
role? Why? How does Lugol's iodine help in bringing down thyrotoxicosis?
Sir, TSH suppression, sir, it reduces the production of TSH.
Is it, Praneet, is it because of TSH suppression?
Lugol's iodine has got only local action, doesn't have systemic actions.
There's a phenomena on which it depends. What is that phenomenon?
Phenomenon.
Yes, Wolff-Chaikoff effect. So what is the difference between Wolff-Chaikoff and what's the other one? Oh, I'm forgetting the name.
Jod-based.
Jod-based dose. What's the difference between the two?
So Wolff-Chaikoff is a negative feedback mechanism when there is adequate thyroxine and thyroid hormones in the blood to reduce the production of.
It's not negative feedback. There's nothing to do with that. Negative feedback takes time. This blocks uptake. What is Wolff-Chaikoff effect? What is the basis behind Wolff-Chaikoff effect? What are the three things which have to be there? The most important is that the thyroid is still under the control of the pituitary. Hello, Praneet?
Yes, sir. Yes, sir.
Right? It's still under the control of. Second, that this is a protective mechanism, that if the patient suddenly is exposed to iodine, the thyroid shuts down. It blocks the uptake of iodine. And third, there is what is known as a breakout phenomenon, where after 4 to 5 days or 10 days, the thyroid comes back to normal. So these are the three factors in Wolff-Chaikoff effect. Right? Now, what is Jod-based dose?
Giving excessive iodine leads to increase in the production of thyroid hormones, sir, where the Wolff-Chaikoff effect doesn't happen, sir.
So you're giving iodine, but in one place it is causing hyperthyroidism, in other places it is causing hypothyroidism, isn't it? Isn't it?
Yes, sir.
And all this is because of the presence of control or lack of control of pituitary. Do you get me?
So in Jod-based dose, yes, sir.
In Jod-based dose, there is no pituitary control over the thyroid. So if you give iodine, the fellow just starts
autonomous
of the iodine and starts producing thyroxine.
Yes,
you get me? Yeah. So you've done an FNAC. Now, what did the FNAC tell you?
Bethesda follicular nodular disease, sir.
Bethesda 2. What is Bethesda 2?
Sir, 2 is basically.
Yeah, what is 2? Praneet, are you there?
Yes, sir.
Oh, you disappear like a Houdini every time. Praneet. Hello.
Hello.
Yeah, Praneet, don't do the Houdini to me, please. Don't disappear.
Sir.
Yeah, what is Bethesda 2?
Sir. The area of undetermined.
Huh? I think you're.
Yeah. Hello, sir.
Yeah, go on. I'm waiting. All yours.
Yes, sir. Bethesda 2 is follicular nodular disease, sir. 3 is atopy of undetermined significance.
Is it?
Yes, sir.
What is Bethesda 1?
1 is non-diagnostic, sir. We need a repeat.
So if it is, you said 2 is follicular nodular disease.
Benign. Yes, sir.
So what is 4 then?
4 is follicular neoplasm, sir.
So what is the difference in follicular nodular disease and follicular neoplasm? Bethesda 2 is just plain benign. There's nothing to do with follicular or papillary or whatever. It just says benign. You get me?
Yes, sir.
And what is 3?
3 is ATP of undetermined significance, sir.
Okay. So if you have Bethesda 3, what will you do? If it was Bethesda 3, what would you
repeat FN cytology after 3 months, sir.
Okay, and still comes out to be 3 then?
Sir, then we can plan for surgical management, sir.
Okay. But in your patient, she's got a large thyroid, retrosternal extension, and it turns out to be Bethesda 3.
So then, because of the retrosternal extension and the large thyroid, I would like to proceed for surgery, sir, because...
Exactly. What about Bethesda 2 now? What will you do for that?
Sir, repeat FNAC after 6 months, sir, and then
No, again
based
in
on
this
that, we
patient.
can...
I'm talking. Why did she come to you? Got a big swelling?
Yes, sir.
With
because of the
Excuse me, I can't hear you.
Sir, because of the retrosternal extension, we can plan for surgery, sir.
No, otherwise also, it's a large swelling. Just because retrosternal doesn't mean that you got to go for surgery. It's a large swelling extending into the retrosternum. Okay.
Yes, sir.
What is the plunging thyroid?
Sir, on extension of the neck or increase intrathoracic pressure, the lower border comes into the neck, sir.
So it moves out on increased intrathoracic pressure and then comes back again, right?
Yes, sir.
Right. Okay. So, and what is the retrosternal goiter then?
So retrosternal is where the lower border clinically could not be assessed, and there is intrathoracic extension, sir.
Right. It will not come out in spite of doing all kind of maneuvers. Okay.
Yes, sir.
So you go in for surgery. Anyone else, sir?
Right.
Yes,
How
sir.
do you know that it is a benign one? What are the signs actually will be giving you a hint that probably malignancy? Because every case of thyroid swelling, should you think it as a benign or a malignancy?
We have to rule out a malignancy, sir.
Yes. So in your case, what are the points which will be differentiating? No, sir, these are not present, so perhaps it is a benign one. Or
even with
signs of malignancy.
Sir, even with a very large swelling, there's no symptoms of infiltration of the trachea. There is no hoarseness of voice. There is no palpable neck nodes, and even on imaging, there were no neck nodes. So there is no swelling elsewhere with features suggesting metastasis like pulse skull metastasis in follicular CA or liver metastasis of medullary CA, sir.
Before that, just you have to also take the history, rapid increase in size, because for 6 years it was present and as a slow growth. If there is a rapid increase in size, that will be giving you a hint also. Any other condition there will be rapid increase in the size of the swellings suddenly?
Sir, hemorrhage, sir. If there's a cyst, there could be hemorrhage into the cyst. It could be an anaplastic malignancy, sir.
Okay. Something about that proximal muscle weakness.
Yes, sir.
Khana sir asked. Okay. Is there any particular name of the test you know? It is done for the thyroid test to find out whether proximal muscle weakness is there or not. Plumer's. Remembering? Plumer's sign. Okay, Plumer's sign. Okay, in your Bethesda classification, as we were discussing, so which Bethesda classification category is having the least chance of malignancy?
2, sir.
2. And maximum?
Maximum 6, sir.
6. And in 1, what is the chance of malignancy?
So around
Zero.
10 to 15%, sir.
5 to 10%. Good. So in that way, actually, we need to. So in case of 2, you can give assurance. And based on whether the size is large, so cosmetic region, or if there is retrosternal extension, you have to go in for the treatment.
Yes, sir.
Okay. Yes, we can go to the management. Yes.
One more question. What is thyroid acropathy?
Sir, there is clubbing, sir, because of so there
Thyroid
will be clubbing.
acropathy. Clubbing. It's one of the signs you need to look for. In case of these are not very there in all the cases. Very severe thyroidosis patients invariably having a thyroid acropathy. That too more of a primary thyroidosis. Okay, go ahead.
More bodies.
Yes, sir.
More bodies.
Sir.
Some of our bodies.
Sir, it is on microscopic evaluation of papillary CA. We see some of bodies, sir. They are due to calcification of due to increased calcification, sir.
That you can see on the ultrasound. If you see these bodies on ultrasound also, that is suggestive of the malignancy.
How they look under microscopy? Characteristic description of that. So what sir is asking.
So rosette, leaves of rosette shape, sir.
Rosette shape. Any popular cartoon you heard? Typically looks up one of the eyes.
Orphan and
yes. Go ahead. For any eyed appearances. Popular cartoons from the America. Cells are eccentrically placed with a large vacuolated cytoplasm. So nucleus is pushed towards the periphery. It gives an impression of the famous cartoon of Arbor Annie. This is called Arbor Annie eyed appearance. Under microscope, they also look like some more bodies because of the calcifications.
What is the differential diagnosis of a solitary thyroid nodule?
Sir, it could be a dominant nodule of a multinodular goiter, sir. It could be a colloid cyst, sir.
Any neoplasm?
Sir?
Any neoplasm? Malignant, follicular, papillary, anaplastic, any?
Yes, sir.
Which is the more prone in MNG, the multinodular goiter?
Sir, a long-standing follicular, sir.
Yes, and long-standing in the MNG is known to go for a follicular carcinoma.
How did you go for FNAC in your patient? How you did that?
Sir, under ultrasound guidance, sir, of the thyroid's 3 nodules, sir.
The bigger and the
well,
which is there, you will take a FNAC from that.
Sir.
Okay. So what is your
does this FNAC has got any other advantages apart from in follicular?
Sir,
can you able to diagnose follicular carcinoma on FNAC?
no, sir. We cannot assess the capsular or vascular invasion on FNAC.
Okay. Is there any newer modality of finding out the suspicious of malignancy even in FNAC specimens?
Not sure, sir.
Please read the newer genetics of the new modality of finding the diagnosis of this one, even on a molecular cytology and the newer genetics. So it is still possible. Otherwise, what we put it as a benign, by doing these tests, at least more than 70% would have been found out. So please go through it once again. The newer advances in the molecular cytology and genetics of the cellular cytology, particularly in follicular neoplasm. Even with an FNAC also, it can be stored and it can be made use for the further diagnosis also.
So should we call it a day because the next candidate is waiting? Ask my.
Yes, sir.
Hello.
Okay.
Yeah. Dr. Kanargal?
Yes,
Hello.
yes, sir. Yes, sir.
Yeah, sure. I think we can start with
Yes,
the
sir.
next case.
Yes, sir. Please, sir. Pranit, do you have any questions to be clarified?
Awesome.
Prakash, sir, I think you have another meeting. Please take leave, sir. Thank you.
Thank you, sir.
Pranit, do you have any doubts to be clarified, Kana? Yes,
No,
yes,
sir.
sir. Yes, thank you very much, sir. All right. Pranit, you can unshare your PowerPoint. Vidisha,
Yes, sir. Yes, sir.
you're okay now?
Yes, sir. Yes, sir.
Give him a moment, let him unshare the PowerPoint, then you can do. Pranit, thanks to CDN sir and Kaliappa sir.
Thank you, sir.
Ishwar sir, good evening, sir.
Good evening, sir. Good evening, sir. Namaste, sir. Sorry, sir.
Yes, sir. Yes, sir.
Joined little late. Little late. I have
No,
traveled.
no worries, sir. No worries. I didn't want to disturb you in between class was
No,
going. I saw you joining
no,
some
sir,
time
no,
back.
sir. Yes, sir.
Yes, sir.
Okay.
Vidisha?
Then
Yes, sir. Yes, sir. I'm sharing the document.
Are you okay, ma? Vidisha, should you take anyone's help, please ask one of your colleagues to come and help.
Yes, sir. I'm not able to share the document. It is showing
You
error.
just listen to what I'm telling. Just close
sir.
all the windows. You have a laptop, right? Okay, just listen to my instructions. You are from your mobile, is it?
Okay, sir. Yes. So this is showing that this is an unsupported document type. Please select an image or a PDF document.
No, you just listen to, you have in PDF or PPT, you sent your PPT only, no? You go to a place where you have better connectivity, Dr. Vidisha. What is the trouble you are facing, ma?
So it is showing that the document I have is unsupported. I have to
Can you
convert it
just
in.
follow what I'm trying to do, tell you?
Yes,
You have
sir.
a laptop, right?
Yes, sir.
All right. Now, shut down all the apps except Zoom in your laptop.
Okay, sir.
Now you press the share screen option. Have you done that?
Sir, wait for 2 seconds.
Pranit? Dr. Pranit? Pranit? Dr. Pranit? I need some help, Pranit. I am just sharing Vidisha's
Yes, sir.
presentation. Can you play in your computer, ma?
Yes, sir.
I am sent you. Can you help her to do that? She's been struggling from the beginning and class is getting delayed. I
Yes, sir.
sent
Yes,
you
sir.
by WhatsApp, Pranit. Please help her to play the slides. Sorry for the inconvenience, Pranit. Did you get the PowerPoint, Pranit?
Got it, sir. I'm just opening it, sir.
Okay,
Just,
okay. Great, great. Dr. Vidisha?
Yes, sir. Yes, sir.
Dr. Pranit is sharing the PowerPoint. He'll help you to move the slides. Start your
Okay,
presentation.
sir.
Faculty, sorry for the inconvenience.
Sorry for the inconvenience, sir, and sorry for the inconvenience, Dr. Pranit. And thank you for sharing the slide.
Good luck,
Okay, good evening.
Good luck.
Oh, okay, sir. Good evening, everyone. I'm Dr. Vidisha Verma, a second-year postgraduate resident from Department of General Surgery, GMC Jammu. Under the guidance of my moderator, Dr. Shyam Kumar Gupta, I'll be presenting the case on soft tissue tumor. Can you go? Okay. Okay, a 40-year-old married female resident of Janipur, Jammu, home tutor by profession, presented to general surgery OPD with a complaint of swelling left flank since 1 year. Can you go to the next slide?
Yes, sir.
Go ahead. Dr. Vidisha, go ahead.
Yeah.
Yeah,
I was.
Pranishas, yeah, that's it.
So the patient was apparently in her usual state of health 1 year back when she first noticed swelling on the left flank region, gradually progressive in size from an initial size of 2 into 2 centimeter to the current size of 5 into 8 centimeter. It is not associated with pain over the swelling, no history of abdominal trauma, no history of rapid progression of swelling, no history of swelling anywhere else in the body. Can you go
Pranish, go
to
on.
the next slide? It is not associated with fever and no history of vomiting, recent unintentional weight loss, altered appetite, altered bowel and bladder movements, night sweats, bony pain, cough, chest pain, hemoptysis, hematemesis, or blood in the stools.
Yeah, Pranish, go on. Next slide.
Patient is a known case of hypothyroidism since 4 years, for which she is currently on a treatment. No history of hypertension, diabetes mellitus, or any CJ disorder. No history of tubercular therapy intake, no history of blood transfusion, history of open hemorrhagectomy that was done 25 years back, no history of similar complaints in the past. Next slide, please. So personal history, patient takes mixed diet and takes regular frequent meals. Bowel and bladder habits are normal. Normal sleep and appetite. No history of tobacco use, smoking or alcohol intake. So family history, no history of similar complaints in the family members. No history of ADT intake in the family members. Obstetric history, patient is para 2 live 2 with one male and one female child. Both were normal vaginal deliveries and both were uneventful. So the menstrual history, patient has been having irregular cycles. The last menstrual period was 2 months back, and the cycles they last for 2 to 3 days usually. So patient is currently on tablet Thyronorm 50 microgram OD. Patient is allergic to dust and pollen. So to summarize the history, a 40-year-old female presenting with a 1-year history of gradual progressive painless swelling in the left flank, increasing from an initial size of 2 into 2 centimeter. No constitutional or systemic symptoms were noted. She is a known hypothyroidism on treatment with a past history of open hemorrhoidectomy 25 years back. Obstetric history is para 2 life 2. All were normal vaginal deliveries and no significant family history is present.
Yeah, Dr. Vijay. So what do you think
Yes,
you're
sir.
dealing? There are
Yes,
some
sir.
glaring mistakes in your history, which I'm going
Yes,
to
sir.
point out later on. First, I want to know what
Okay.
you're thinking. What do you come to? What is the conclusion of the history?
Sir, from the history, I think the swelling is most likely benign. It can be a lipoma, it can be a sebaceous cyst, or it can be
The
a
basis
lumbar.
system.
Yes, sir.
Okay.
It can
Okay.
be a lumbar. Yes, sir.
It can be a lumbar.
Hernia.
Lumbar
It
hernia.
can,
Okay. Lumbar
depending
hernia
upon the site.
and
Sir, depending upon the site of the swelling.
so
You
it's a left flank swelling
mentioned
without
left
Yes, sir.
flank, no?
left
Yes, sir.
flank,
Yes.
right?
Yes, sir.
So
Yes, sir.
sebaceous cyst and okay, lipoma is fine. Lumbar hernia, no cuff impulse, no the other features of hernias.
No, sir.
So why lumbar hernia? What would be a next? What would be a more intelligent differential in this? Okay, I say accept lipoma. Any more intelligent differential?
So it can be liposarcoma and it can be
It can be it can be
hematoma.
a retroperitoneal tumor. It can be a
Yes,
hematoma,
sir.
but there's no history of this thing. Can it
Yes,
be
sir.
a psoas abscess?
Yes, sir.
Okay,
It
now
can
let's
be
go to
cold
your history.
abscess also. Yes, sir.
Have you taken history for low back pain? Have you taken history for any weakness in the lower limbs? Any neurological symptoms of the lower limbs? Any
Yes, sir.
any changes in color of the lower limb? Any swelling of the lower limb?
Yes, sir. Yes, sir. So
You
there
have
was
not.
no history.
Where's your history? You have to specifically take for this, isn't it? If
Okay,
there's
sir.
something from the retroperitoneal, right, it's going
Okay,
to
sir.
involve the aorta. It may involve the IVC. It may involve the nerves. It may involve the
Yes,
spine,
yes, sir.
right? So all this history has to come up, even if
Yes,
it's
sir.
negative,
Yes,
right?
sir. Yes, sir.
Any difficulty in bending, any difficulty in movement of spine, if it's a psoas abscess,
Yes, sir.
right? So all this is missing in your history.
Yes, sir.
So once you come to your diagnosis or your differential, you should go back and
Yes,
then
sir.
complete your history. So
Okay,
anyone
sir.
else?
One more question on the history itself. How can you make out whether it is a parietal swelling or whether it is intra-abdominal swelling?
No, sir.
Because
We
you are
cannot.
keeping the possibility of lipoma, sebaceous cyst, all these things comes under the parietal wall of the abdomen. Okay.
Yes, sir. Yes,
In
sir.
your complaint, it is a history of swelling in the flank. Flank means again the anterior or posterior. Invariably,
Yes,
we
sir.
conclude the flank means is always the upper abdomen on the left side. Upper
Yes, sir.
abdomen, invariably, anteriorly. So coming to the lumbar hernia, most of the time it comes in the posterior part of the flank. Okay, so you have to
Yes,
divide
sir.
it
Yes,
very,
sir.
very clearly whether it is the anterior part of the flank or posterior part of the flanks.
Okay,
Okay, and the
sir.
history is very difficult to conclude whether it is the parietal wall swelling or intra-abdominal swellings, unless you have got other associated symptoms. This particular patient,
Yes, sir.
apart from known hypothyroidism, there are no other complaints.
Yes,
So
sir.
what made you to think that it is a parietal wall swelling like lipoma or neurofibroma, neurofibrosarcoma? How you decided that? On history
Sir,
level?
the duration of the progression of swelling. So it was 1 year. The swelling was 2 into 2 centimeter, and then it gradually progressed to the current size of 5 into 8 centimeters. So the
It,
duration was long,
the
and there
proper
were no constitutional. Yes, sir.
one more, the 2.2 centimeter tumor to be noticed by the patient. Okay. So it has to be the abdominal wall. Otherwise, 2.2 centimeter, any intra-abdominal swellings, I don't think patient would have been able to make it out. So that is one interesting
Yes, sir.
point.
Yes, sir.
You got it, no? 2.2 centimeter, it is smaller. It will be noticed only when it is in the superficial part of the abdominal. So invariably, it is in the parietal wall. So now
Yes, sir.
I can make out probably. It could be lipoma also. Okay.
Yes,
Looking at the size.
yes,
Okay.
sir.
Any other intra-abdominal complaints you need to ask about these things?
So history of loose
History of
stools or constipation.
loose stools. Why you want to know? Ask me.
Any intra-abdominal mass which is also extending in pelvis, it can cause loose stools or tenesmus.
No. History of any similar swellings elsewhere in the body. Is it important history?
Yes, sir. Yes, sir. Yes, sir.
Why? Why it is so?
Sir, if there are multiple swellings in the body, it
Yeah.
changes the diagnosis.
Yeah, definitely. If the patient complained of one more swelling elsewhere or similar swellings elsewhere, then your diagnosis should have been more appropriate. It could be multiple lipomatosis or it could be
Yes, sir.
multiple neurofibromatosis, either of these
Yes,
two.
sir.
Okay, if it is painful. Okay, go ahead with it.
So what are the various types of like?
So the lipoma, it can be subcutaneous. Based upon anatomical position, it can be subcutaneous, intermuscular, subfacial, subsynovial, then subserosal.
When you get a lipoma in the bone,
Sorry, sir, I can't hear you.
when you get a lipoma in the bone,
Yes, sir. Periosteal lipoma is also there.
subperiosteal.
Yes.
What is a universal tumor?
Yes, sir. Lipoma is a universal tumor of the body. It
Any
can
other
be
name?
present anywhere. So it can be. It is also called ubiquitous tumor.
Yeah, it's also called as ubiquitous. Okay.
So which is the commonest lipoma in which location?
Sir, subcutaneous lipoma is the commonest lipoma. It is present in nape of the neck, shoulders, or back.
Down wall also sometimes.
On the examination.
Dr. Puneet, can you switch to next slide? Okay. So general physical examination, patient was fully conscious, alert, of average build, normal gait, normal decubitus in bed, and normal attitude of limb. Vitals were recorded. Blood pressure was 120 by 80 millimercury per mm per Hg. Pulse was 84 beats per minute. Good volume, regular, bounding, no radial or radiofemoral delay. Wall was not palpable. Saturation was 99% on room air. Respiratory rate was 18 breaths per minute. Weight was 55 kgs. Height was 154 centimeter and BMI of 23.19. Next slide, please. So on head and neck examination, pallor was present. Cyanosis, icterus, edema was absent. Trachea centrally placed. No lymphadenopathy was present. No enlarged thyroid gland. No congested neck veins were present. On chest examination, bilateral air equal air entry with normal vesicular breathing was present. On cardiovascular examination, normal heart sounds were heard. No added sound or murmur was present. On musculoskeletal examination, no joint swelling, tenderness, or limitation of range of movement or loss of any muscular power was present. On neurological examination, motor power and reflexes were intact. Next slide, please. So on abdominal examination, on inspection, abdomen was non-distended with a centrally placed umbilicus which was inverted. No visible vessels or pulsations were present. No visible peristalsis or pulsations were present. No scar was visible. Solitary swelling, it was visible in the left flank region. So the site was left lower flank region at the umbilical plane. The size was approximately 6 into 8 centimeters. It was a dome-shaped bulge or spherical in shape that distorts the normal flank contour. The position of the swelling was, it was in the left flank, left lower flank or left lumbar region. Plane was at approximately umbilical plane and posterior. It was situated posterior laterally. It was best seen on the lateral view. It was not prominent on the anterior view. The surface was smooth, edges were well defined. Skin over the swelling, there was no overlying skin changes, no erythema, no punctum, or no scar visible. Though no visible pulsations over the swelling were seen. On cuff impulse, there was no visible cuff impulse present. There were no peristalsis visible over the swelling. On palpation, no tenderness over the swelling was present. There was no local rise of temperature. The site was left lower flank or left lumbar region. The plane was approximately at the umbilical plane. Relationship to iliac crest, it was 2 centimeters above the iliac crest, and it was 4 centimeters situated below the left lower costal margin. It was positioned between the posterior axillary line and iliac tubercle. It was approximately 6 into 8 centimeters, spherical or hemispherical in shape, smooth lobulated surface with well-defined and smooth margins. It was of uniform soft consistency, and the slip sign was also positive.
Shape, how can you mention that spherical and hemispherical both?
Sir, the lower margin, it could not be distinguished, but approximately 80% of the shape, it could be distinguished as spherical.
You know the difference between spherical and hemispherical?
Yes, sir.
How will you make difference?
So the spherical has.
Can you see the 360-degree of the swelling?
So I can view the 2D image of the swelling only. I can't view the
It cannot be
whole
both.
depth of the swelling.
Until unless you see the 360-degree, then only you can call it as a spherical swelling. So if you're
Okay,
seeing
sir.
only the 70% swelling, you should restrict to the hemispherical swellings. Okay.
Okay, sir.
This abdominal wall swelling is very, very unlikely to be a spherical because you will not see the remaining part, 1/3 which
Yes,
is
sir.
there in the abdominal wall also, and maybe intra-abdominal also. Okay, better
Yes, sir.
word is hemispherical swelling. Okay.
Okay, sir.
Okay.
Okay, sir. Next slide, please. So the fluctuation was absent. It was it was not a translumination positive. The skin over the swelling was freely mobile over the swelling, and the swelling was somewhat fixed to the underlying structure. It was not freely mobile. There was no pulsation felt. No, it was non-reducible, non-compressible in nature, and there was not any organomegaly associated with it.
The better word skin over the swelling is whether it is pinchable, non-pinchable is the better word you have to mention.
Okay, sir.
You should not use the freely mobile over the swelling. The better word is
Okay.
skin is pinchable. That it indicates
Okay,
that
sir.
skin is not adherent to the swellings.
Okay, sir.
Then you also mentioned one more thing on inspection.
Yes, sir.
Could you able to make out what is the plane of the swelling?
Sir, on palpation, the plane of swelling, it was.
Inspection,
Achha,
on
okay, sir.
inspection.
Okay, sir. On inspection, it was most likely in the subcutaneous plane.
How do you make out? How do you make out? Have you done any other test?
On inspection, sir.
Ah. How do you make that it is subcutaneous? I may say the intramuscular, I may say the intra-abdominal also.
Yes, sir. Sir, I asked the patient to contract his muscles.
Yes. Yeah. What test you have done it? How do you ask him to contract the muscle?
I asked him to
Ask him
bend his knees and
what is it? It is more of a posterolateral, no? Part of them is
yes, sir.
coming
Yes,
under the
sir.
anterior also. So how do you
Yes, sir.
contract the abdominal muscles?
Sir, by making the patient lie in a supine position and ask him to shift his hips to the opposite side.
Do the leg raising test or head raising test?
Yes, sir. Yes, sir.
Or both together? Both together. In way you are
Yes.
contracting all the abdominal muscles. What will happen to the size of the swelling?
Sir, if it is subcutaneous, on leg raising test. If it
So
is
what happened to in this your patient?
okay, sir. So when the patient was asked to raise his leg, raise her leg, the swelling it became less prominent, and it was fixed to the muscle. So it was an intramuscular swelling, not a subcutaneous on inspection also.
What happened to the size of the swelling to call it as an
So,
intramuscular? Is it increase or the decrease in size?
so the swelling decreased in size.
So the decrease in size, the plane of the swelling is not the subcutaneous then.
Yes, sir. Yes, sir. It was an intramuscular swelling. Plane was intramuscular.
Even in intramuscular also, on head raising leg raising test, the swelling becomes more prominent.
Okay, sir.
Even in subcutaneous also, it becomes more prominent because when you contract the muscle, this swelling lies anterior to the muscles. If the muscles are contracted, the swelling is pushed forwards. It becomes more prominent. Then only we'll call it as a parietal wall swellings. If it
Okay, sir.
becomes less prominent, it should be intra-abdominal only.
Okay, sir.
This is the test you have to differentiate parietal wall swelling from the intra-abdominal swellings.
Intra-abdominal.
Then more than
Yes,
you
sir.
have mentioned that also there is no cough impulse. That itself rules out the possibility of a lumbar hernia also.
Intra-abdominal.
Lumbar
Yes, sir.
hernia. No cough impulse.
Yes, sir.
Okay, continue.
Next slide, please. So on percussion, there was dullness on the percussion of the swelling. The rest of the abdomen had tympanic nerve. No fluid thrill, no shifting dullness was present. On auscultation, no bruit heard over the swelling. No ball sounds over the swelling was present, and normal ball sounds were heard over the rest of the abdomen. Next. Okay, on examination of spine, it was normal on examination. No tenderness was present. On digital rectal examination, the perianal skin was normal on inspection. No evidence of any mass coming out of rectum. The anal tone was normal. Anal mucosa was smooth. No evidence of any fissure, fistula, hemorrhoid, or swelling was present. Fecal staining of the gloved finger was present. On pervaginal examination, bilateral cornices were free and non-tender, and there was no adnexal mass palpable. So, to summarize, a 48-year-old female presented with a 1-year history of gradually progressive paleness swelling on the left flank, increasing from an initial size of 2 into 2 centimeter. No constitutional or systemic symptoms were noted. On local examination, a solitary semispherical 6 into 8 centimeters soft lobulated swelling was noted in the left lower flank. Overlying skin was normal and freely mobile. Slip sign was positive. Swelling was non-tender, non-reducible, non-compressible in nature. It was fixed to the underlying structure, dull on percussion with no foul sound on auscultation. Digital rectal examination and pervaginal examination were unremarkable. So the provisional diagnosis is lipoma of left flank. The differential diagnosis are liposarcoma, lumbar hernia, cold abscess, a sebaceous cyst, dermoid cyst, desmoid tumor, a neurofibroma, and a retroperitoneal tumor.
Did you check for the renal angles here?
Sorry, sir.
Have you checked for the renal angle?
Yes, sir. There was no tenderness or mass palpable over the renal angle.
You percuss over the renal angle?
No, sir.
The normal percussion note over the renal line.
Sorry, sir, I could not hear you.
What is the normal percussion note over the
Yes, sir.
renal line?
Sir, dull note.
Is it dull or it is resonant?
Sorry, sir, can't hear you.
Is it dull note or resonant note?
Resonant.
Renal languages are dull or resonant?
Sir, I'm not sure.
Yeah, resonant
Okay, sir.
because of the colon which is there,
Okay, sir.
ascending over the descending colon, and that is why this is shifted to anteriorly when there is a renal lump.
Yes.
What did you check in the spine?
Sir, I checked for the spinal tenderness.
What else?
If there was an, yes, sir.
What other findings can be there?
Sir, in case of spine, involvement of spine.
This patient, your differential diagnosis, the cold abscess is there.
Yes, sir.
What you can get in the spine?
Sir, spinal deformity is also there in case
Okay.
of cold abscess.
Any other things on palpation?
In case of cold abscess.
Yeah.
So the swelling can be tender and
No,
it
spine,
can be.
spine. Sir is
Okay,
particularly asking about the
okay,
spine.
okay, sir. So the
Deformity could have
spine,
been there. Then anything else?
so tenderness, deformity,
Yes,
the spinous
tenderness and
process.
deformity. Okay. What disease you keep in mind?
So if there is cold abscess, it can be due to tuberculosis.
Pod spine. Okay, it's a pod spine.
Yes, sir. Pod spine.
Okay.
Spinal deformity is there.
Yes,
Dr.
sir.
Vijita,
Yes, sir. Yes.
look, your differential takes care of every possible thing which can be. How
Yes,
can
sir.
you confuse a sebaceous cyst with a retroperitoneal tumor, with a lumbar hernia? You can't.
Yes, sir.
They're entirely different entities. Differential diagnosis means that something which you have to differentiate. There's be some similarities and some differences between the two. You can't have a sebaceous cyst masquerading as a lumbar hernia.
Yes, sir.
You get me? So
Yes,
I
sir.
have got strong objections to your differential. A liposarcoma, a lipoma, or a retroperitoneal tumor, neurofibroma on the skin, unlike or cold abscess. These three could have been, but a neurofibroma, a sebaceous cyst, or lumbar hernia, they've got no place here. Your history doesn't corroborate it. Your examination doesn't corroborate it.
Okay.
You get me? I would
Yes,
like
sir.
you to strike those off. Sir, please.
Do you find any signs when you call it a sebaceous cyst?
So in the examination itself.
Yes, on the examinations. The diagnostic
Mm.
sign of a sebaceous cyst.
So
Then will it
there
appear
is
such a big
punctum.
size around punctum? Is there any punctum in all the cases? And what
No,
is
no,
punctum?
sir.
What is punctum? Can you define the
So
punctum?
punctum. Yes, sir. It is a keratin plug, because of which there is a formation of sebaceous cyst. So it is a black colored keratin plug at the center of the swelling.
Okay. Can it be sebaceous cyst without the punctum?
Sir, in some large sebaceous cysts, the punctum may not be clearly visible.
Yes. If it is punctum is there, it is a more of a diagnostic of sebaceous cyst. If it is not there, still it cannot be possibility ruled out. It can be still possibility of a sebaceous cyst, particularly in a large variety. Okay.
Yes.
Then retroperitoneal tumors, as sir said, Raju sir said, you cannot put it as a differential diagnosis in this case. Okay.
Yes, sir.
One is purely an intra-abdominal, one there all comes into the parietal wall. So you cannot put these in the differential diagnosis. Okay, there are two extremes of your diagnosis.
Yes, sir.
Lumbar hernia, you can be easily rule it out because when the moment you mentioned that there is no cough impulse in that area, that rules out the possibility of a lumbar hernia. Then that's why
Yes,
sir
sir.
was asking what is the renal angle, whether it is dull or recurrent. Okay. Most of the time they present just beneath the renal angle, lumbar hernias. They're more of the posteriorly placed. Then classical sign is coughing versus present invariably.
Yes, sir.
Then cold abscess, unless it is a fluctuant swelling, the pseudo fluctuation you have mentioned here, that is a possibility. But on examination of the spine and there is no tenderness, you can easily rule it out with the possibility of a cold abscess. Don't club with the retroperitoneal tumor. Okay.
Yes, sir.
Liposarcoma, until unless you have got signs of fixity, hardness, in a known case of lipoma, then only think of. You cannot keep the possibility of liposarcoma as a differential diagnosis. Unless exams ask you what are the other complications you're likely to expect, then your answer could have been the liposarcoma possibilities. So you cannot put the differential diagnosis as a liposarcoma until you have got a strong evidence to say that there are malignant signs like hardness, immobility, skin is tethered, larger size, rapidly growing in size. All this history are supportive, then only you can keep the possibilities. Okay. In this
Yes, sir.
case, most probably you have to put the lipoma as the first diagnosis. Differential diagnosis you can think of, but not these entities, what you have mentioned.
Okay, sir.
What is the deformity, spinal deformity in case of the cold abscess? What is that deformity?
Yes, sir. Sorry, sir.
What is the spinal deformity in the cold abscess?
Sir, so kyphosis.
Why there is kyphosis?
Sir, due to compression of the body, the spinous process they become more prominent.
Okay, what about either the disc is involved or whether the body is involved in case of tuberculosis?
So disc is involved. So the body
Oh no, disc is never
they're
be involved
clubbed
in case of
together.
tuberculosis.
This one.
Tuberculosis invariably it is a body, bony portions will be involved because of the destructions, it collapses. Disc will be invariably normal in case of tuberculosis. As a result, so it collapses, then there will be kyphosis deformities. There is a prominence of the spinous process. If you look from the back, there will be prominence in the spinous process. In tuberculosis, disc is invariably spared.
This is called as the gibbous deformity also.
Gibbous, yes. Yes.
Yes, sir.
This is POTS spine. Do you know what are the other places where POTS is used? Apart from this
Sorry,
place,
sir. Sorry,
POT
sir. I
comes
can't hear you. Sir,
asking that
I can't hear you.
you're not able to hear me.
Sir.
Hello.
Yes, sir. I can hear you.
What are the various conditions where the name of POTS is associated?
Name of the POTS is other conditions. POTS.
So due to port spine also there is POTS paraplegia.
Okay.
Then
Have you heard what is POTS puffy tumor?
yes, sir. Yes, sir.
What is that?
It is a tumor of sebaceous glands over the nose, over the face, and particularly involves the nose.
POTS puffy tumor.
POTS puffy tumor is osteomyelitis of the scalp. You get me?
Yes, sir.
Yeah, it's nothing. That's rhinophyma, which you're talking about.
Oh, okay, sir. Okay, sir.
What is POTS fracture?
So, I'm not sure.
Okay, now how do you proceed? Dr. Vidisha, how do you proceed?
Yes, sir. Yes, sir.
How do you
Okay,
proceed?
So, sir, I'll go for the radiological investigations. First of all, I'll get the blood investigation and then the radiological investigations.
Why do
I'll
you want
go
to
for
get a
the
blood investigation first before radiological? Why blood
so
investigation first?
as to look on the hematological picture
What do
because
you want to do?
if the condition is malignant.
Dr. Vidisha,
Yes, sir. Yes, sir.
investigations to confirm your diagnosis, to confirm your investigations to confirm
Confirm
your
the
diagnosis first, right?
Okay, sir.
to
Okay, sir.
diagnose the
So,
disease, then confirm the
okay,
disease. So what is
okay,
the
sir.
thing to diagnose the disease?
Sir, I'll go with ultrasound and then ultrasound
Right.
guided FNAC.
Your blood test will not give you anything. Even if it's malignant, what will it give you?
So,
What
in
do you
case of
expect?
malignancy,
Yeah,
yes, sir.
go on, go on.
Okay, sir. What did you ask?
I said, in case of malignancy, what blood
Yes,
picture
sir.
are you expecting?
So, in case of malignancy, there will be increased lymphocytes or leukocytes. The
You
blood
think this is
picture will,
hematological malignancy?
no, sir.
No, it isn't. You'll not get anything in your blood picture.
No,
You
sir.
may not, until and there are secondaries. So blood picture doesn't help you. It's ultrasound. Okay. Have you got the
Yes, sir.
ultrasound report with you?
Yes, sir. Yes, sir. Can you
Let's
please
have
go to the next slide? Okay, so on ultrasonography, there was a evidence of large isoechoic lesion measuring 3.9 into 2.2 into 4.2 centimeter noted in the left lumbar region with no vascularity on color Doppler. It was likely suggestive of lipoma. So on FNAC, it showed fragments of mature adipocyte tissue with fatty background. Cytomorphological features were suggestive of lipomatous swelling, and the HP was strongly suggestive of lipoma.
Okay. 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 Now what do
So
you do?
this was so since the in radiological investigations and the FNAC, they are strongly suggestive of lipoma. So I can go for the next plan for surgery, that is wide local excision of the
Okay, what are
swelling.
the types of lipoma you know?
Sorry, sir.
What are the
The
types of
types of
lipoma
lipoma.
you know?
What are the?
Types of lipoma, you know.
Oh, okay, sir. So, sir, it can be subcutaneous, it can be intramuscular and intermuscular, it can be subserosal, it can be uh, periosteal, it can
Where
be
they
No,
where they are absent,
periosteal.
yes, sir.
they can present everywhere except some
Uh,
places. Can you make out where some places?
so it is not present in brain, except for
Why?
brain, it can
Why?
be
Why?
present. Yes, sir.
Why it is not in the brain?
Because brain does not have any fatty tissue.
Yeah,
It does not have
it
any
doesn't contain any
fat cells.
lipomatous tissue also. Hmm.
Yes, sir.
Any other place other than brain?
Uh,
What is continuation of the brain?
so spinal cord,
Yeah, spinal cord. There could be an extra lipoma.
extradural.
Can be
Yes, sir.
there, but intradural unlikely.
So
Because
also in the eye, the tooth,
Mm,
you don't have
yes,
all
sir.
this. Okay. Okay. So one is what did you say? The lipoma? What are the types?
Yes. Yes,
What did
sir.
you say about the types? Types of lipoma?
So subcutaneous, intramuscular, subserosal, periosteal, then lipomatosis disease
one
or
more.
adiposis dolorans, and then diffuse type of lipoma is also there. That is also known as pseudolipoma.
Okay.
Can it be
What
there
about
inside the joint also?
Yes, sir.
Can
Yes,
it
sir.
be there
It
inside the
can.
joint?
Yes, sir. Synovial lipoma.
Yeah, I didn't mention it. It's called intra-articular lipoma.
I-
Also
Okay,
called
sir.
as.
Okay. Okay. Can it be what is angiolipoma or fibrolipoma?
So if the lipoma has some fibrous tissue, it is also known as fibrolipoma. And if the lipoma has some vascularity, some vessels are present or plexus are present, then it is known as angiolipoma.
Where it is commonly present in angiolipoma?
So
They are known to cause bleeding inside also. It can be surgical emergency also many times.
I don't know.
Angiolipoma of the kidney. Many times patient
Yes,
presents
sir.
with
Yes, sir.
acute bleed inside, come to the emergency, the sudden increase in the pain and swelling. Okay. The diagnostic sign is an ultrasound. It will make out the lipomatous tissue with the hematoma formation inside is one of the diagnostic for the ultrasound examinations for the angiolipoma.
Yes, sir.
Okay, so you go. Suppose it's arising from within the muscles.
Yes, sir.
It is diffused.
Yes,
And
sir.
what will you do? You can't excise the whole of the muscle.
No, sir.
So would you like to go
Sir.
for any other investigation?
Yes, sir. Sir, MRI.
Right. You just prefer an MRI, right? It will tell you exactly where the cells are arising from. Okay.
Yes, sir.
So what did you go for surgery?
Yes, sir. Yes, sir. So we
Okay.
excise the whole of the swelling.
So what are the complications now of surgery?
After the surgery, there can be early or late complication. The early complication can be formation of hematoma, can be formation of seroma, infection. The late complication can be scar formation and recurrence, or even malignant change in the remaining tissue.
Okay. So suppose it turns out to be a liposarcoma.
Yes, sir.
Now what do you do?
So we will do the wide excision of the tissue surrounding
How
the
wide? How wide?
sir, we will take 2 centimeters of the edge uh, from the swelling, and we will excise all of the swelling along with the 2 centimeter of normal tissue, and we will send the biopsy sample for HP to look for any involvement of the margins.
What was the size of your tumor?
So it was 6 into 8 centimeter.
So the margin depends on the size of the tumor also. You get me?
Yes, sir. Yes, sir.
Right. So if it's more than 5, then you have
Yes,
to
sir.
take 2 centimeters.
Yes, sir.
So anything? I think we've done.
Local excision for lipoma.
Sir?
Yes, sir.
Professor Khanna?
Did you say that you will do the wide local excision for lipoma?
Yes, sir.
Wide.
Why? No, no, sir. We will do complete excision, including all the tissue which is present in there, along with the capsule.
Has it got capsule for lipoma? Does lipoma have capsule? Does fibroadenoma has got capsule?
Yes, sir.
So it moves within the breast like a mouse.
Yes, sir. Yes, sir.
Whereas lipoma, it is a pseudo capsules more of the surrounding
Yes, sir.
compresses surrounding tissues. Okay, they are not well capsulated.
Yes, sir.
Complete excision is good enough.
If this swelling would have been a little higher up,
Yes, sir.
patient had the chest symptoms, what you will think? What can be the swelling?
Sir, if the swelling is higher up and with the chest symptom, sir, what was your question?
The swelling is slightly higher up near the costal
Yes,
margin,
yes,
and the
sir.
patient had chest symptoms.
Sir, it could be a cold abscess.
Cold abscess is okay. Anything else? So cold abscess, you have told about that.
Yes, sir.
Anything coming from the pleural cavity?
So it could be a hematoma.
pleural cavity. You know any type of empyema which can present as a swelling, subcutaneous swelling?
Yes, sir. The empyema thoracis
Empyema necessitans.
necessitans.
What is the diagnostic sign? Empyema necessitans, how you diagnose that? Any cough impulse you'd like to do?
Yes, yes, sir.
Yes. Ask the patient to cough. So you could see a bulge in the area, in the intercostal area.
Yes,
So
sir.
that is one of the diagnoses for empyema necessitans.
In case if it comes out to a cold abscess, what is the treatment?
So it will be we will give the patient anti-tubercular therapy.
How will you confirm the diagnosis of cold abscess?
So by doing sputum for CB-net or interferon gamma test,
Would you like to
or even
not do
ADA levels, we can check for
anything
ADA.
local area?
Yes, sir. We will send the pus culture for CB-net and
How you drain them? How you drain it? When you strongly suspect it could be a cold abscess, and what is the method of
yes,
drainage?
sir.
Have you heard about non-dependent drainage?
Yes, sir. So we will drain anti-gravitally.
Why?
So because of tuberculosis, it has a propensity to the tract remains there for a chronic period of time, and it has a propensity to
Yes, go for sinus formation.
go
So to
for
avoid sinus
yes, sir.
formation, you have to go for a non-dependent drainage. The material what you aspirate, you have to send for diagnostics test for that. Okay,
Yes,
CV
sir.
net you can have it, and you can have a smear also, and you can have a culture also to look for any secondary infections. Once
Yes,
you
sir.
confirm, then only you have to put the patient on ADT.
Yes, sir.
You know, what are the recent changes which has been made in the treatment of the tuberculosis? In the primary tuberculosis.
Sir, so the drug pyrazinamide has been removed as a primary treatment.
Which drug has been added? Which drug has been added? Is it a 6 months treatment or 4 months treatment?
Yes, sir.
Is it now a 6 months treatment or it is 4 months treatment?
So 4 months treatment.
Reduced to 4 months treatment, and pyrazinamide has been removed from that, and
Yes,
moxifloxacin
sir.
has been.
Okay, sir.
And in place of the rifampicin, there is another salt of the rifampicin is there. I think probably it is rifamid or something like that.
Rifabutin.
That has been added in that. So 2 months, 2 months treatment. So it's the total 4 months treatment.
Can you wind up, sir?
Yeah, I think we can wind up.
Thank you, Vidisha. You need to read some
Thank you.
more
Thank you,
for
sir.
the clinical, particularly clinical examinations and findings. One should correlate with your clinical examination and the diagnosis. Okay?
Yes, sir. Yes, sir.
Kanagwal, sir?
I think we've done most of it. So, Dr. Karagal?
Yes, sir.
I think we've done so.
Both have done fairly well, sir. Both have done fairly
Yes, sir.
well.
Any other doubts to be clarified, Dr. Vidisha? Do you
No,
have any
sir.
questions or doubts to be clarified?
No, sir.
Okay. Sir, Kanna sir, Ishwar sir, other faculty, any other comments, sir? Can we call it a close, sir? Rajiv sir?
Close.
Yes, sir.
Shyam sir, you would like to give any comments?
No, sir. Thank you very much, sir, for all the support. She had a hitch in the beginning, but you have your patience and you let the
No,
student.
sir. That happens, sir. That happens. I should thank Praneeth for holding the fort today. Otherwise, the second
especially
session
thanks
would
to
have gone. I
Praneeth,
think
sir.
Praneeth has stayed back with us too. Thank you, Praneeth. Thank you for hosting us the PowerPoint.
Thank you very much, sir. Thanks once again, sir. Thank you.
So, the permission of the faculty, we call the session a close. Thank you very much. Good night, everyone.
Good
Thank
night,
you,
sir.
sir.
Good night, sir. Good night. Good night. Good night.
Thank you, sir.
Thank you,
Thank
Kanna
you.
sir,
Thank
Raju
you.
sir. After a long
Thank
time,
you,
I
sir.
have participated.
Yeah.
Sir, come back often, sir. It's a request.
Sure.